Okay, the stepladder. I don't have any clue why I came up with that name, but I did. And it's long ago, probably 30 years ago now. And I used that to describe a style of treatment. First step on the stepladder, steroids. Second step on the stepladder, non-steroidal anti-inflammatory drugs like Aleve, Naproxen, Motrin, and so forth. Third step on the stepladder, immunosuppressive therapy like, for example, methotrexate. Fourth step on the stepladder, the so-called biologics like Remicade. And the fifth step on the stepladder, surgery. One of my colleagues from Chicago some years ago approached me at a national meeting, and he said, "Steve, can you please stop talking about the stepladder in your publications?" And I said, "Well, what's up?" And he said, "Honest to God, if I have one more patient come into my office and ask me where I am on the stepladder, I'm going to shoot myself." The stepladder is just what I've spoken to you about, and it's what the rheumatologists have always employed. They got it wrong years ago, and they learned a hard lesson. They did the stepladder in the way that I just described to you, always starting with the lesser of the potential evils with aspirin and sulfa and so forth and so on, in a base-down pyramid model of increasing aggressiveness of therapy. They eventually learned, though, that a lot of those patients treated under that model were ending up with permanent, disabling joint pathology. And so some of the more wise and thoughtful ones, began to flip the pyramid up on its tip, up on its apex, and come in earlier and bolder with disease-modifying agents. And doing that, they began to notice much, much better outcomes, and oddly enough, and a little bit counterintuitive, frankly, less toxicity from drugs. And so the cry became throughout the entire world of rheumatology, the mission is remission. Pursue remission. Come in bold. Snuff it out. Get the disease into remission and prevent permanent disability. So we believe that we can learn an important lesson from the rheumatologist's experience. I mean, after all, think about it. How much less, without developing permanent damage, do you think a retina or an optic nerve can stand in the way of inflammation compared to a joint? You know, you end up with some joint pathology. Well, you can still live a very, very nice life. You develop a little retinal pathology in your macula and your optic nerve, you're cooked. You're finished. You're disabled. You cannot drive. So the therapeutic principles that we espouse in terms of the stepladder are shown here. Do whatever it takes to preserve function of retina, optic nerve, the eye. Of course, do a subconscious calculation of the risk-benefit ratio. By that I mean, for example, if a person has both eyes involved, one needs to get the inflammation under control more urgently than if there's one eye involved. If the person has violent inflammation, they need control much more quickly than if the inflammation is more subtle. And so I will not choose the biggest shotgun in my arsenal to treat a patient whose uveitis is, yes, it's important, but it's not the worst case I ever saw in my life. So a risk-benefit ratio calculation. Understand the diagnosis simply means to the ophthalmologists, we don't want to be treating syphilitic uveitis with immunosuppressive chemotherapy or herpetic uveitis with immunosuppression. We want to make sure that we've done our duty in determining to the extent possible an underlying cause. Then, of course, there is my good old friend, the stepladder. and then the admonition to use a chemotherapist for those eye doctors who get it and know that they should move along to steroid-sparing immunosuppressive chemotherapy. They're not comfortable doing it, get a partner. Dan Gordon, who used steroids first, learned a lesson pretty quickly that one wants to come in and really get it snuffed out. Don't diddle around and use a little bit and that doesn't work and then use a little more. Just come in and snuff out the fire, like calling the fire department rather than grabbing your garden hose and turning it on the fire. You've heard some of these drugs mentioned today. I will tell you that this is a partial list of the things that we employ at Mercy in the quest to induce remission of active inflammation. The eye doctors in this audience today, I would venture to guess, are unfamiliar with probably half these things, and that's okay. But I will tell you that it's only going to get worse. As Patrick mentioned earlier, something new now in Europe. Every year here in America, there's something new coming along. And we can bring all those things because of getting permission for off-label employment for vision-threatening inflammation. We bring it all to the battlefield. So, again, primarily for those in the audience who are eye doctors, I will tell you that all these things that you hear me saying are not mine. None of it's mine, actually, except for the stepladder. None of it's mine. I get a lot of credit for it, probably because I'm so vocal about it. But I want to share with you that there are other groups who have visited this subject matter long ago, reviewing peer-reviewed literature, and coming to the conclusion that much more needs to be done with earlier employment of immunosuppressive chemotherapy in the care of patients with vision-threatening ocular inflammation. Some have gone so far as to say that there are certain diseases that absolutely require the employment of such therapy, that to use corticosteroids only in patients with these diseases basically amounts to malpractice. They feel that the results in peer-reviewed literature speak so strongly to the fact that long-term outcomes of these disorders treated with corticosteroids alone are so poor that it is negligent not to treat concurrently with steroids plus an immunosuppressant and eventually taper and discontinue the steroids. They also believe that these disorders that I'm listing here are worthy of strong consideration for the employment of such a style of therapy. Again, because long-term outcomes in patients with these things, when steroids alone are used, are relatively poor. And the evidence is that the outcomes when one uses steroid-sparing IMT or immunomodulatory therapy earlier on in the game are much better. The American Uveitis Society is the specialty society for inflammatory disease in America, and they convened a panel of 12 doctors, rheumatology, pediatrics, and ophthalmology, to go through that same kind of exercise that the European group did, namely, to review the world's literature on the quality and strength of the evidence for the employment of immunosuppressive chemotherapy for patients with ocular inflammatory disease. And they found that they concluded there was good evidence for effectiveness and for the need for such therapy in patients with pemphigoid, necrotizing scleritis, sympathetic ophthalmia, multifocal choroiditis and panuveitis, serpiginous choroiditis, Behçet's disease, birdshot retinochoroidopathy, and JIA and other diseases. Now, you've heard this word Behçet mentioned 2 or 3 times so far. I'll just emphasize to you that's the name of the Turkish dermatologist who first described this disease in widely read literature in the German dermatologic literature in 1937. And it's a horrible disease that has horribly blinding ocular consequences. There's a patient here right now who has that disease, and any of you who want to speak to her and get a sense of what her experiences were like and what it took to get her into remission, and she has been in remission for years now, are welcome to do so, she let me know. It's Joanne Zeiss who's raising her hand over there now. Well, what about mischief making? You heard Patrick address this briefly about the risks. What are the risks to such therapy? In the quest to save sight, are we also producing trouble? Are we killing anybody? Are we producing premature development of cancer in anybody? By the way, what would you guess? Raise your hands. The risk, randomly selected population of people off the sidewalk, you get 100 of them, and you end up asking the question, what's the risk of developing a cancer in the next 25 years in that group of 100? How many would say that it's 10%? How many would say that it's 20%? And how many would say it's 30%? It's about 30%. So those of you who raise your hands at the 20 and 30% level really are quite bright. Is that risk elevated in those people who are exposed to these kinds of drugs? Nope. I'll show you that momentarily, but I just wanted to share with you 160 of my patients studied by Michael Sampson, who's now at the New York Eye and Ear Infirmary in New York City, asking the question, in patients treated with methotrexate for the sake of the eye, how often do we produce trouble? Well, here it is. Here's the trouble. 160 patients, 8 of them ended up with elevated or rising liver enzymes. What do you think? Is that a problem? That's not a problem. That's the whole point of the blood testing every 6 to 8 weeks. You see them rising, you back off on the dose, the liver gets happy, the enzymes drop back into the normal range, and off you go. What about the leukopenia, the dropping white count? Is that a problem? That can be a problem, but again, it really is not a problem because that's the whole point of getting those blood counts, as Patrick Whalen mentioned earlier. If you see the white count dropping, you ease off on the dose. If it continues to fall, you simply stop the drug. They will always recover. Those other things like nausea and feeling lousy can be problems. They can be deal breakers. We do not at Mercy push our patients to just suck it up and keep taking any medication if it's negatively affecting the quality of day-to-day living. But you've already heard there are at least a dozen, if not more, drugs that we can pick and choose from to get the job done, get the patient into remission. Here are the cancer data from our study many, many years ago, looking at 543 patients on various immunosuppressive chemotherapy drugs. And these data, if you do the calculations, these data actually turn out to be less than the expected cancer rate in a randomly selected population. And then from a multi-center trial, abbreviation of which is CITE, a huge number of patients over 5 centers, including the National Institutes of Health and Mercy. The death rate and the development of cancer rate was no greater in those patients who were exposed to these kinds of drugs than to the general population. So, here's the stepladder. Stepladder approach in the care of patients with uveitis is first the employment of corticosteroids, drops, shots. There's our favorite technique of giving the shot. Oral, pills, intravenous infusion. Most of you know about the infusion suite at Mercy. But we don't do this endlessly. It is the fire department. Come to me and put out the fire, and then I'm going to take it away little by little by little, watching carefully for recurrence. If the disease recurs, then of course we'll treat with steroids again, but we're not going to just treat with steroids. We're going to have a conversation about immunomodulatory therapy for long-term remission. And that may be with something as relatively innocuous as a daily oral nonsteroidal anti-inflammatory drug like Celebrex or Naproxen. Some patients do need pupil dilation in their acute care. Some patients will need pressure management during the acute care. And subacutely, that is to say a month or so into it, you're tapering the steroids, pressure still has to be paid attention to because it may affect as many as 30% of patients with uveitis, and if it's not carefully checked for, visit after visit after visit, lo and behold, one can end up getting burned with vision loss from glaucoma, never mind that you got the uveitis into remission. The pressure management can be done with drops most of the time, including prostamides. Lumigan and Travitan are just fine, we have shown, in our care of patients with uveitic glaucoma. Xalatan, not so much. Seems like some provocation of inflammation or macular edema can occur with that one. Lasering. It was thought that lasering, tickling the trabecular meshwork with laser, might be provocative of flare-ups. Nope, it's not. SLT lasering is just fine for uveitic glaucoma. Between valves and mitomycin C trabeculectomies, I used to have a strong bias toward the valve. Not so much now. We see that well-done trabs, including express shunts, probably are just fine in many of our patients with uveitic glaucoma. Chronic therapy, bone preservation. How many of the eye doctors in the audience who have patients, never mind if it's scleritis or uveitis or whatever, you've got them on systemic prednisone, how many of you get a DEXA scan? Let me ask a different question. What do you suppose the timing is for the onset of significant death of bone-producing cells in the bone? It's 3 months. I'll bet most of you didn't know that. Most of you thought it was a year, 6 months. It's 3 months. So getting a baseline DEXA scan and counseling on smoking cessation, supplemental calcium and vitamin D, weight-bearing exercises at the early time point in the use of systemic prednisone is very important. And if it looks like they're going to be on the steroids, they've got giant cell arteritis, for example, and they're going to need systemic prednisone, you know for sure, more than 3 months, it's probably appropriate to at least have a conversation about Forteo or bisphosphonates or salmon calcitonin or other strategy for bone building. Chronically, steroid-sparing immunomodulatory therapy. More needs to be done with less fear of doing so because of the evidence that I've tried to lay out to you today and that's available to you in the literature just with your own PubMed searching. Drug implants have a place. This is the Retisert. We use Retisert at Mercy, especially in patients who are already pseudophakic or aphakic and don't have a steroid response history with respect to steroid use. That's one of ours there. And then, of course, the new kids on the block, the so-called biologic response modifiers, with Remicade leading by far in terms of usage in my hands at Mercy. I do like Rituxan. I do like Humira. I love and hate IVIG. Fantastic stuff, unbelievably safe stuff, but a real pain in the you-know-what logistically to use. And then finally, of course, one can get involved with the final rung on the stepladder therapeutic approach to the care of the patient with uveitis, and that is surgery. Surgery is not rare in the care of patients with uveitis because of all the kinds of problems that come to you, eye doctors, in the patient who has been treated ineffectively or inefficiently, insufficiently over the years, and they now have their cataract. Much better to avoid that complicated uveitic cataract than to deal with it after it's developed. Much better to avoid the development of the glaucoma than to have to deal with the glaucoma after it's developed because of insufficient delayed therapy. And vitrectomy, of course, may be required both therapeutically and diagnostically. Here's an example of a patient that was sent to me long ago. You know, many of you, that we were the first to put lens implants into the eyes of patients who had had uveitis and developed cataract and then were put into remission and they needed a cataract out. And the question was, could the eye tolerate the presence of a foreign body, an intraocular foreign body? It's not a normal eye, that's for sure. And so we did a series of studies, of cases, and found that in carefully selected cases, the eye could tolerate the intraocular lens implant. The optics were terrific, much better than having to use contact lenses and so forth. But not all eyes of all patients with uveitis can tolerate the presence of that foreign body after the cataract is removed. And I've published on 19 cases where the lens implant had to be removed. And this is particularly an issue with pediatric uveitis. So those parents here who have the child who is in remission, but they've got the cataract and they need cataract surgery, you need to have this conversation with your ophthalmic surgeon. In your heart of hearts, if this were your child, would you put a lens implant in my child's eye? I so-called wrote the rules about selecting patients for lens implant. This one obeyed the rule, the doctor obeyed the rules, and it didn't work out. The implant is nasty, it's scarring, it's being pulled through the pupil. Of those 19 cases that I published, 2 of them were mine. You'd think I could get it right. I don't get it right all the time. So we tell the patients, we tell the parents that if we do this, if you choose to have a lens implant, and the eye has grumbling chronic inflammation, it's better to go back in and take it out rather than just kind of try to suck it up and tolerate it. So, to finish, the standard of care, in my view, the preferred practice pattern, in my opinion, in the care of the patient with uveitis requires, number 1, appropriate evaluation. They do need diagnostic studies. Number 2, put out the fire before permanent retinal damage is done, and you do that with corticosteroids. Number 3, always be aware of masquerades from infection or cancer. Cure infection by discovering it and using the appropriate antimicrobial, such as acyclovir for herpes, penicillin for syphilis, and so forth. Number 3, limit the use of corticosteroids to prevent cataract and glaucoma. Do not get on a steroid treadmill, and always be aware of the potential steroid complications to chronic steroid use, both to bone and to eye. The early employment of immunomodulatory agents, in my strong judgment, is the key in these children who have chronic or recurrent uveitis. Thank you so much.